When payers look at subpopulations in various areas like PH and PAH, but certainly across the board when we're talking about these complex conditions, we are not focused on the total cost of care as much as the cost for individual members, mainly because the prevalence of these subpopulations is typically so low that from a plan-wide perspective, we're talking about frequently fractions of a penny per member per month, which is the metric that health plans use to look at costs, per member per month costs. Now, certainly the individuals may be very expensive and probably will be very expensive. And I've had for many years, one of my roles is to sit with employers and review their high cost claims list, people who are using a lot of services and spending a lot of money. And when patients show up on those lists who have things like PH and PAH, and certainly if they're in a subpopulation which is at even higher risk and require even more resources, a lot of questions come about, such as what is going on, explain this condition, and that's one of our roles. However, from a plan perspective, again, the costs in total for subpopulations and even entire conditions, or the condition as a whole for something like PH, pales beside the costs we see for oncology, for heart disease, for diabetes, orthopedic implants, many of those other areas which have very high utilization, not as high cost per member necessarily, but just in terms of the volume and prevalence. When there are multiple agents available for treating a general population or even a subpopulation, ultimately our goal is to make sure that our medical policies reflect the current standard of care, the FDA label obviously, and also anything that is really salient and pertinent from the evidence-based literature. We also want to incorporate recommendations from National Professional Society guidelines if they are available. It may well be that for a certain population you use drug A and then drug C, and you'd use drug C plus drug B at a certain point. Again, that is ultimately going to be a decision of the clinician. Our goal is just to make sure that those requests that we receive from the clinicians are in line, again, with the best evidence-based literature, the current standard of care, and the FDA label, so that we can target these agents as appropriately as possible to make sure that we're getting the optimal clinical outcomes. When you think about fragile patients, patients who have many drugs, which we call polypharmacy, they certainly represent a very important focus both for the clinician but also for the health plan. Now, the ultimate decisions on treatment, drug A versus drug B, that is going to be the decision of the clinician based on that particular clinical scenario. But as a health plan, we have long recognized that polypharmacy is a huge issue for patients with these complex chronic conditions. We have always used our tremendous data sources to identify members with polypharmacy. Anyone at Humana who is on one of these specialty drugs gets a contact from a pharmacist on a monthly basis, and the purpose of that contact is several-fold. We want to find out how the patient is doing. Do they have any questions about their treatment? When was their last visit with a clinician? When is their next visit? Do they have any issues around testing or other ongoing needs that they might have? And very importantly, when are we going to ship the next dose of the drug to make sure that it gets to them safely and in a timely fashion? One of the things that we also seek to do is to make sure that we are understanding if the patient is having any problems accessing care, if they have questions about some of their benefit issues. One of the challenges for anyone who has got a condition like PAH or PH is seeing multiple providers, going to multiple sites, and getting obviously many claims coming to their door. And one of the things that our care managers and pharmacists do is help them wade through that to make sure that they're addressing their concerns and their issues.